Good evening, everyone. My name is Raymond Dilla. I'm from the Clinix Health Group head office. I'm glad to be with you again this evening as we commence with our session. And we are glad that this evening we have another discussion on some of the exciting topics of the day. But before that, we just want to request that everyone please make sure that you unmute your mic, and when the time comes for a Q&A, we will allow you to unmute your microphones and you can speak and ask questions. But you may also use the chat group to pose your questions. Dr. Miller will be able to respond to those questions later on. And know that this webinar is CPD accredited. Please ensure that when you register, you submit all your contact details about the regulator that you are registered under, and give your practice the registration number and also your email address, so that at the end of the session we should be able to give you the certificates. And also we will be at the end of the session, either tonight or tomorrow morning, we'll be sending out questionnaires to all the participants, those who are logged in tonight and those who have ever logged in before, since we started with these webinars in the previous year. We just want to get your opinion about how we can improve our webinars, content and speaker that we invite here, topics that you want us to cover. But also there's a question that is paramount in our minds about the starting time. We meet every Thursday. Last week we started at 7 o'clock, but this evening we're back at 18 hours, 6 p.m. We shall keep this time slot 6 p.m. But we want you to give feedback as to which is the best time for this webinar. So please do provide us with your feedback. And we also request that you stay logged in until the end of the presentation, because there is a monitoring system to check how long you've been engaged with us, so that we can then provide the CPD points according to the time that you are with us. If you leave earlier, you risk the chances of not getting your CPD points. But thanks, we have this evening a topic, a quite topical discussion, COVID-19 variants, how concerned should we be? Many questions have been asked, and I think we saw it yesterday, the questions been asked, but I think we've got a speaker of note to be able to unravel some of these questions this evening. Professor Stephen Miller is a member of the microbiology, virology, and cell culture team at Lancet Laboratories. He's also the medical director of the Innovire Institute, a registered trust providing state-of-the-art laboratory diagnostics, clinical trial opportunities, and patient care services for people with HIV/AIDS. He's a graduate of the West Medical School, following a period of postgraduate training overseas in cardiothoracic surgery. He returned to Johannesburg and joined the South African Institute for Medical Research, where he qualified as a clinical microbiologist. He was appointed Associate Professor of Clinical Microbiology in 1989, shortly before he entered private practice. After several years of laboratory-based work, Dr. Miller migrated to the clinical practice of infectious diseases with an emphasis on HIV medicine and research. His involvement in the field dates back to 1984, when he helped establish the HIV clinic at the Johannesburg Academic Hospital. Since then, he has lectured and published widely on HIV infections and has served on several local and international AIDS planning committees. He is a founding member of the HIV Initiation Society of Southern Africa and has served as chairperson of its inaugural Treatment Guidelines Committee. He has been a principal investigator in many international collaborative trials and continues to play an active role in clinical research. And it is an honor for us this evening to have Dr. Miller welcome, Prof. Miller, and we hope that we know that we're going to gain quite a lot from you this evening, and there'll be a lot of interactions after your talk. Thank you.
Thanks, Dr. Biller. I certainly don't recognize myself in that CV. I think those are past lives, and my current work is a lot more focused on the general diagnostic virology environment. And for that reason, I am happy to chat to everyone tonight about the topic of COVID variants. So I just want to check, does everyone see the screen, the slide on the screen? We were having a little difficulty earlier, so I just want to be sure that you can all see it. Do you see the slide, Dr. Biller? Okay, okay. So, okay, yes, I can. Thank you, thank you. So, as you said a little bit earlier, the topic is a very common one at the moment, and much has been said about the possible problems or concerns about COVID variants. And so tonight, what I'd like to do is to run through the subject with you. I haven't got lots of very technical slides, but where there are a few issues that we need to look at in some detail, we can go through that together and slowly point out what needs to be highlighted. I'm just trying to move the slides, and it looks like we're having just a bit of a problem. Give me 1 second and I will try to refresh that for you. Okay. I'm assuming everyone can see this slide at the moment. Is that correct? Because I don't see anyone else right now. I just see the screen in front of me with the slide. Can someone just confirm that you can see the visuals before I start talking about this?
We don't see your slides.
Okay, let me try again.
Yeah.
This is the
and
problem.
Please let me allow myself to unmute myself anytime. Don't mute me.
Okay. Let me see here. I'm sorry about this, but I think it's here. Let me see. Do you see a single slide on the screen?
Not yet.
Okay. We will get there. Let's just be a little bit.
Take your time. We're all here waiting for you.
That's what worries me a little.
I shouldn't have said that. It's coming up. I think it's coming up.
Now, do you see it?
Yes, we can see the slides.
And do you see 1 or 2 slides?
We see 2 slides.
Okay, so let me see if I can get rid of the second one. And hopefully that will make things a little bit more pleasant to look at.
Okay. Both, okay. Yeah, I think should be 1 slide. Let's see.
You're seeing 1 slide now. Okay.
Let's see what, yeah, 1 slide, yeah, sure.
Okay, perfect. Then, okay, so now the problem is whenever we see 1 slide, it doesn't move. You can see with that very extensive CV that you read out, I still can't work, a computer screen. Yes.
Dr. Miller?
Yes.
Hello.
Kamu here. Please click on the slides and then try to move with the, thank you.
Okay.
Yeah,
Do you
it's
see
moved.
one now?
Yeah, it's
It's
moved.
working now. Thank you, Doctor.
Okay, all right, everyone, we should be fine now. So when we talk about variants, we have to discuss in some detail the notion of genetics in this specific virus called SARS-CoV-2, which is the causative organism of the illness that we call COVID-19. And what I'm trying to show on this slide is on the left-hand side, I'm not sure if you can see the arrow, but on the left-hand side is just a general sketch of what many viruses look like, but in the main part of the screen, we can see the structure of the SARS-CoV-2 virus in more detail. And what we have here is we have this round structure, which is the virus itself. We have these little yellow structures called the spike protein, and this will become an important topic as we go through the presentation. And then on the inside, we have got this very wiggly purple structure. And what that is it's the genetic information of this virus, which is found in the form of RNA. And it's quite a complicated set of genetic information which encodes a large number of features of the virus. So let's look at that in a little bit more detail. What is a mutation? What is a variant? What is a strain? These are terms which we hear being used quite often, but without much understanding of what the term means. Let's have a look at the top part of this diagram on the right. You will see there the structure that we saw in the previous slide, which is a cartoon, if you like, a sketch of how the RNA of the virus, the genome, is made up. And there are specific regions of the genome which serve particular functions. Our greatest interest here is this little area in purple, which is called the S gene or spike gene. And it's here in this region of the genome that everything happens that ultimately results in us seeing the phenomenon of variants. So we have to understand that all SARS-CoV-2 viruses look very similar from the outside. And you can see in this funny little table on the right-hand side, that purple gene is constant throughout that virus population. But if you look across in these little squares here, which indicate the building blocks of this spike gene, you will see that there are differences. In the top line here, we have a little blue block indicating there is a particular kind of change at a certain position in the genetic code of the spike protein. And as you go further down from block to block or line to line, you will see that although all these viruses have from the exterior a common appearance, once you look at the interior of the genes, you will see that there are some small changes. And these mutations, or these changes, we call mutations. So a mutation, as you can see from the text, is a specific change in a building block of a gene, in this case, the S gene. And when we have changes like this, which are small and scattered throughout the genome, we talk about each of those virus populations with that particular change in the genome being a variant. So a variant looks for all the world like its ancestral, it's the ancestral virus from which it derived. But when we look at the interior of the virus and look at the genetic building blocks, we will see that there are these individual mutations which we can discern with very special techniques. But from the outside, the virus still looks the same. Depending on the changes that we see in these variants, we can give that particular variant of the virus a certain designation, and we'll come to that shortly. If at some later stage, or with the appearance of one or more of these mutations, this virus now starts to become different, either in its appearance or in how the body reacts to it, how it moves from person to person, or the disease that it produces. Once we start to see that becoming a definite characteristic, we no longer talk about a variant, but we describe that as a new strain of the virus. And what I want you to see as we go along, that up to this time, we do have a number of variants of SARS-CoV-2, and that many of them are found in this country. But as yet, there has not been a significant change in the features I've mentioned here. And so we do not as yet have any new strains of the virus. So the question of variants is not new. If you have a look at these maps and you look at the top map here, you will see this is a description of the virus when it was first discovered, December the 3rd to February the 3rd, 2020. And what we saw, even in those very early days of the COVID epidemic, was that the main source of the virus was here in China. And very rapidly in the first 3 months, two groups of this virus moved out of the place where it was first found. So we have what is called a lineage of the virus, one of which went from China through parts of Asia to Australia, from there to America, and then a separate lineage which went across to Western Europe. And you can see even in the first 3 months of the initial epidemic, these changes in colors along some of these lines. And what that represents is the presence of variants of this new virus. And have a look what happened about 3 or 4 months after that, by the time the virus got to South Africa, and we saw the onset of the epidemic here. Well, you can just see worldwide, there is this massive dissemination of the virus, lots and lots of variants all over the show. So the presence of variants of SARS-CoV-2 is not a new phenomenon. It's been there from the beginning. It's happened now. In all likelihood, it will continue to happen over time until this organism comes under some sort of control throughout the world. And in fact, scientifically, when the viruses in South Africa were looked at with very specific genetic methods, it was clear that even in the first wave, around 40% of the viruses that were circulating at that time, a year ago, were already variant viruses. It just was not a term in common currency, and nobody seemed to be that concerned about it. So it's only recently that this has come to the fore as a potentially important phenomenon. And we now have many, many variants worldwide, but here is a diagram of what I'm calling the big three variants. So on the left here, we can see the variant that originated in the United Kingdom towards the end of last year. It has basically migrated or been carried into other parts of the world, so it's quite widespread. And it's given this name which no one needs to remember. There is the so-called South African variant, which was discovered at more or less the same time. It has moved in small numbers to other parts of the world, but lockdowns and travel restrictions have really made it a variant that's largely confined to South Africa and other parts of Southern Africa. And then there is the one of current concern called the Brazil variant, which was found more recently and seems to be starting to spread now with travel, both to the Far East, also the United Kingdom and other parts of Europe. And all of these are of concern because they have become the dominant viruses in these parts of the world. So if we look at South Africa and we look at the second wave, the vast majority of infections have been due to this variant rather than the original virus and variants that we saw a year ago. The same is true in the UK, where their variant is very, very common if you look at their infected population. And no one's quite sure what the extent yet worldwide is of the Brazilian variant, but people are obviously looking at this with a lot of interest. So this is what we need to remember, that variants are not new. We've had them since the beginning of the epidemic in South Africa. And the dominant variant now in 2021, the so-called South African variant, is given this alias. So we call it the 501YV2 variant, okay? The question that's been raised, and that's not just here in South Africa, but worldwide, and this applies to all of these three major variants, is does this variant, this dominant, most prevalent variant, increase the transmissibility of the virus? You've heard a great deal of that in the news media. Does it get controlled by the immunity that built up from an infection in the first wave? Or can it escape from the antibodies that were produced in that period? If it's different genetically, has it got an impact on the lab tests that we use for diagnosis? Most importantly now, as we are approaching the time when hopefully the vaccine will be rolled out in the country, we want to know what's the impact of this variant on vaccine efficacy? And then lastly, is there a clinical difference that has been seen when this variant has infected people compared to what was seen previously? To understand some of these issues, we need to look at a few technical issues. So here are the few technical slides that I mentioned. At the top here in red and blue, you can see a sketch of SARS-CoV-2. And on the surface, these red spikes, which as the virus approaches the lining of a human cell, which you see at the bottom here in yellow, that spike gets attracted to a chemical on the surface of the human cell called the ACE2 receptor. And once it binds to that, which requires it to be changed by an adjacent protein enzyme that we all have on our cells. So once that is changed by this TMPR protein enzyme, that spike easily engages with this receptor on its host cell, and that pulls the virus into the cell and sets up infection. So the spike protein is really the attachment device that is critical in establishing infection. And because the variant has changes in the spike protein, all of the questions I had in the previous slide have arisen. And here we see what happens in real life. So this is a portion of lung tissue looked at under a very high-powered microscope. You can see the coronavirus particles with these little fringes on them, the spike protein. They are adhering in some places to the ACE2 protein in cells that lines these air sacs. And very rapidly, they will enter into these cells and start to cause problems that will soon lead to the person becoming ill and possibly even succumbing to the infection. So let's look at our common variant and ask the question about transmissibility. Yes, it's plausible that this virus could be more transmissible. And I'm going to go back a slide to explain why that is. So if something happens to this red spike protein that increases its ability to attach to its receptor, theoretically, it could much more easily cause infection. New viruses will be produced in large numbers, and very quickly those new viruses could be transmitted to someone nearby. The concerns about transmissibility, we must remember, have not been based on any laboratory tests. There's been no confirmation yet in scientific studies that this variant is more transmissible. People have raised this possibility based on the fact that the second wave has been so large in terms of numbers. And that's been the case all over the world. So the assumption has been that because we have more people getting the infection and the majority of them have this variant, and it's happening over a short period of time, that this variant could possibly be more transmissible. The problem here is that this ignores one of the key factors about the spread of SARS-CoV-2. And that is that people are poorly adherent to preventive measures. So we could have a very, very transmissible virus, but the truth is, if people behave themselves in the way they've been advised to, there's no way for that virus to move. And what we know about the second wave in South Africa, certainly, is that we have seen events like this. And I don't think it takes much of an imagination to realize that you can have the same old SARS-CoV-2 that we saw last year getting into a situation like this, and the end result is going to be something that looks terrible. You're going to see huge numbers of infection, not because the virus is different, but because you're allowing the virus to spread in the way that we know it does. So here's what we saw in Africa as the second wave appeared. We saw a higher peak in a shorter period of time. And as you can see here, these figures highlight South Africa and Morocco, not because there was anything special about the second wave in these countries. It's just that South Africa and Morocco have the most competent testing facilities. And so the numbers that came out of these two countries were probably more reliable. Well, what people forget is if we look at the period between the first wave and the second wave, there was a lot of virus in our community. So probably in truth, if we had reduced the amount of circulating virus to lower levels, it would have been more difficult to experience a wave of this magnitude. And until the scientists sought out what was more important here, the virus characteristics or the fact that people were not protecting themselves adequately, we cannot say for sure that this virus is more transmissible. We can look to other countries. Let's look at the United States. There have now been several million infections with 500,000 deaths in their second wave. They don't have this variant. They don't have the UK variant. They don't have the Brazilian variant, but we're seeing exactly the same pattern. And we know from good studies conducted in the United States that people between the ages of 15 and 49 during the second wave were remarkably non-compliant with public health recommendations. So this is a question that remains to be resolved, but by no means can we say with certainty that this is a more transmissible virus. So what about the second question? If somebody has had COVID a year ago and made antibodies, and just remember that not everybody does make antibodies, but assuming we're looking at people who did make antibodies, would those antibodies protect one from a second infection, this time with the variant? So what do we know? We know that antibodies developed during the first wave may not fully protect one against the common variant virus. And that's based on laboratory tests. In fact, in the laboratory, we can see that taking plasma from people recovering from a prior infection with COVID, that the antibodies in that plasma do not necessarily neutralize the variant as strongly as the original virus. So this, of course, is cause for concern. But again, this is a very big picture from which we can't draw detailed scientific conclusion. We don't know whether what's being done in these very small laboratory studies is relevant to the real life situation. Why is that? So the first thing is that we don't know what level of antibody is required to protect a person from infection by COVID. So it may well be that when we look at antibodies produced last year from infection with the original virus, and antibodies produced now from people who have the variant virus, that they may not neutralize equally. But until we know what the actual level of neutralization needs to be, we can't interpret that phenomenon in any scientific way. And unfortunately, the tests which have been approved for use in South Africa at the moment don't measure neutralizing antibodies, nor do they measure quantity of antibodies. Now, I know some people think that when they get a laboratory report and it's got a little value next to a result which says positive, that value means nothing. That is a reading from a machine. It is not a titer, it is not a quantity, and we cannot use it in any way at this time to say, oh, person A has more antibodies than person B because the labs reported a value of 10 on one report and 4 on another report. If you took those people's samples and reran them together on different days on the same machine, you'd get different values coming out. So please don't be confused about that kind of so-called information. So we don't know yet very much about how much antibody do we need to be protective, nor do we have the capacity at the moment to tell us if the antibodies we are measuring are neutralizing. So once again, the question about reinfection, which is obviously where this is leading, remains speculative. Lots and lots of what I'd call anecdotal infection, lots of anecdotal descriptions, I should say, of possible reinfection. But you know, to prove reinfection, we need two things. We need to show that the genetic code of a virus that someone may have now is different to the code we found in the virus they may have had a year ago. And we also need to confirm the fact that someone has a new infection by means of culture. Remember, all the tests that we do right now, whether it's an antigen, a PCR, do not tell you if the virus you're picking up is alive or whether you're just picking up dead bits of the germ. So there's still this very, very big gap. And at the moment, no one is offering routine culture facilities. It's still being done only for research purposes. So the truth is that worldwide, well-documented reinfections are rare. And if and when they occur, they are probably related to the fact that antibodies decline over time. So it's not that one had COVID last year and made antibodies that are now not protective. It's much more likely that someone had COVID last year, made antibodies, which have now disappeared, as we know they do, after about 6 to 9 months. And therefore, they may be susceptible to infection with any variant and possibly even the original virus they had. So again, lots and lots for us to find out here. But now that we have tests that are coming through that will give us much more information, we should be able to answer this question in a couple of months. Does the presence of variants impact on our PCR tests? And I'm only talking about PCR now because it's still the gold standard for picking up the presence of the virus. Well, when we do a PCR, we look at a host of genes. If you remember that little diagram right in the beginning with all those discrete areas in different colors, we look for most of those in a test. So we look for an S gene, the spike, the envelope gene, and so on, as you see here. Since the variants typically have changes in the S gene, it does not materially affect the results of a PCR because we have all the other gene results to look at and interpret. And I think it's important to say that although very complex chemistry and machinery goes into getting a PCR result, every result is reviewed by either a scientist or a pathologist before it is issued. In that way, we do our very, very best to not over-report or under-report. And that certainly won't be a bigger problem now that we have a preponderance of variant virus causing infection in the country. Vaccines, most important strategy we've had up to now to control this epidemic. And it's a key question that everyone has to ask, and correctly ask, which is, if you give a vaccine and you induce immunity from the vaccine, will that immunity protect you? Or is the vaccine not going to be as effective as you thought in the beginning? So let's look at what makes a vaccine effective. And this includes COVID vaccines. Firstly, the vaccine must give rise to an immune response, a protective response in the person who's been vaccinated. And I'll mention here and come back to this shortly, that immunity is based on two different things: the presence of antibodies, which is the stuff we talk about so often, but there is also a cellular component to immunity, and it's critical in people who have all sorts of viral infections. So immunity must look at both of these arms of the human protective response. Secondly, we want to know what is happening clinically. Whether or not we have lots of antibodies and lots of cellular immunity, does giving the vaccine cause milder illness and prevent death? So yes, it's possible some people may get a trivial infection, but how many people who are vaccinated now have to be admitted? How many need ventilation? How many need ECMO? How many are going to demise? So we want to look at the clinical efficacy of the vaccine. And lastly, from a public health point of view, we want to know if one's given the vaccine and it doesn't work 100%, you still have some people who get very mild infections. Are they able to spread that mild infection to other people in the same way as would be the case if that person had not been vaccinated? So these are all the things that are looked at in terms of vaccine efficacy. So the first question is, the vaccine, which is based on the spike protein, the one where we see the variations, is a spike-based vaccine not going to work as well against a variant than the original virus? And the answer is, it's probably still going to work extremely well. And the reason for that is we tend to think simplistically. We think, oh, spike protein, one kind of antibody. That's not the case. In fact, the spike protein is extremely complicated in its structure. I'll show you a picture of it now. And therefore, it doesn't just give rise to one type of antibody, but it gives rise to a whole population of antibodies. The end result is that maybe one or two of those antibodies may not be able to stick onto that variant spike as well as to the original spike. But there are many, many other antibodies that can still exert a protective effect. So real escape, which is the technical term, is escape from vaccine antibodies a strong possibility? Probably not. And we'll see this in a little diagram I'll show you now. We have data on all of this for 3 approved vaccines, actually 4 now, and more data coming on a 5th vaccine. And we'll briefly go through that in just one slide. and look at it in relation to this question, because I know a while ago you had a very detailed presentation on COVID vaccines, and I don't want to repeat much of that. Okay. So what are we looking at here? At the bottom of the slide, this curved structure is the surface of the virus. You see sticking out from it this big blobby structure here, which is a complex chemical, and that is the spike protein. It has different chemical regions, and each of those regions gives rise to a different kind of antibody. So the spike protein, we know now, gives rise to at least 4 different antibodies, all of which bind in a different way. So what you can see here diagrammatically is what we would like. At the top of the slide, the horizontal bar is the membrane of the host cell. This little blue blob dangling down there is the ACE2 receptor. And these funny structures, which are sticking to the spike protein, are antibodies, showing you how they bind to the spike protein. And it's quite clear when you look at this, it's going to be very difficult for this spike protein to attach to its receptor. The antibodies are going to block that. And that will prevent infection and therefore prevent illness. So this is the optimal situation that we would like. Okay. Unfortunately, this slide is upside down compared to the other one, but it's exactly the same. Here at the top is that curved membrane of the virus. Here is the red spike protein sticking out and showing you its complexity. And at the bottom here is the ACE2 receptor on the cell. And what we can see in the spike protein, these white spots and the little letters next to them, these are the 3 typical mutations that we see in the South African variant. There you can see the N501Y mutation is sitting right at the edge of the spike, at the tip where it engages its receptor. And so this area is called the receptor binding domain. Normally it would give rise to an antibody. But when the 501 mutation is there, the antibodies that it gives rise to do not stick very well. So there's a possibility it can still engage its receptor even though antibodies have been formed. I use the word possibility because if we look at this in a slightly different way, on the right of the slide, that gray structure there is in fact the spike protein looked at in another view. And you can see there are 4 so-called classes of antibody which are produced by vaccines. And so even though one of them may not stick directly to the receptor binding protein, the others stick to regions very close to it. And as we saw in the previous cartoon, they will still interfere with the virus being able to stick to its cell. So yes, we may not get as strong an antibody response, but there's enough over here to prevent binding. And we see that when we look at the clinical results. Let's just look at this column here, or this line, which says efficacy. You know all these names already. There is the Moderna virus and the Pfizer virus, which have shown in studies worldwide a 94% efficacy. What does that mean? It means that these vaccines reduce the amount of severe disease, hospitalization, and death by around 94, 95%. So notice what I said. The endpoint, the efficacy, is a clinically based endpoint. So what's happening with the antibodies and so on, we'll learn about in time. But despite what antibodies are made and how they stick to the spike protein and all that kind of stuff, you can see that from a clinical point of view, the vaccine is very, very effective. The Oxford AstraZeneca vaccine has problems of data. We don't know if it's a problem of the vaccine or just that the trial that was done, especially in South Africa, had too few people, was not representative of the population, and we therefore can draw no conclusions from the very low clinical protection it gave. So I think for now, we must wait and see, because that's being corrected with further studies. But because of that, rightly, there is caution about using it as the favored vaccine. And so the Johnson & Johnson is the one that is going to be rolled out first when the proper rollout starts. And again, we need to understand there is no rollout yet in South Africa. There is a clinical trial, but the general population has no access to vaccination. And really, one can only hope that that will change very, very rapidly. So what we see over here is with the Johnson & Johnson vaccine worldwide, so this is not specifically affected by variants, worldwide, 66 to 70% of people who receive this vaccine do not get severe illness, do not need hospitalization, and in fact, it protects almost 100% against deaths. In South Africa, where we have the 501 variant, what we saw was slightly fewer people getting full benefit from the vaccine, but around about 60% of people who've received it in the clinical trials did not get severe disease, did not go to hospital. And I think, if I'm not mistaken, in the entire clinical trial group, there were something like 3 deaths compared to many, many, many more in the people who did not get the vaccine. So it's a vaccine that works to prevent death and severe infection, and it's therefore still a very worthwhile vaccine to give. It has the advantage of being a single dose, and it's also easy to handle compared to the strict refrigeration requirements and short shelf life of the others. So have the vaccine now and encourage it, because 70% protection against being really sick and almost 100% protection against death is nothing to be sneezed at. For all of these vaccines, that there will be boosters that will be required in a year or two if we see more substantial changes in the virus. But there is no reason not to get good protection now. And this is the last vaccine which is about to be registered in large parts of the world, the so-called Novavax vaccine, which is again a different composition to the Johnson & Johnson and has given very good results worldwide with pretty much the same protection in South Africa as the Johnson & Johnson. So if we go back to the question, does the variant that's present now mean that the vaccine's not going to work? What we can say is it works against severe infection, it works against protection from death, and it markedly reduces hospitalization. We may, however, still see some people with mild infections, but obviously not ending up in a very severe clinical condition. So studies are now coming out looking at our second wave and looking at answers to these questions. Has the variant created a group of people who are more ill than we saw in the first wave? Have we had a greater mortality in the second wave than the first wave? And the statisticians who are looking at this data tell us that the answer is no. We've not seen a greater proportion of people becoming severely ill. We have not seen an increase in mortality. What we have seen is many, many more people with coronavirus than we saw in the first wave. And therefore, the numbers have been more overwhelming, but the proportion of people with difficult to treat infections is much the same as we saw in the first wave. What we have seen, and this is important for us to do more research on, is that with this variant, if we look at the viral load in the swab from the nose or the throat and compare it to the viral load we saw in the first wave, those viral loads are definitely higher with the variant. And we see that PCRs stay positive for longer in people who've acquired the variant than the original virus that was around. So what does this mean? We don't know. There is a myth that viral loads in the upper respiratory tract predict disease progression. We know that's not true. It would be nice if it was, but there are so many factors that affect viral load management, that measurement, that it's really an unreliable test. We cannot make hard and fast decisions on that. And the question then is, will this prolonged shedding increase transmission? Well, we think it doesn't, as I mentioned much earlier, but what we need to look at is what is the nature of this genetic material? If it's just fragments of a virus which has died or been killed, and those fragments are just being excreted, not infectious, then clearly this is of no great clinical significance. But once we start culturing on a more routine basis, we will want to know, does this prolonged shedding reflect not degraded virus, but living virus? That may change the situation. So if you like, that's a work in progress. Lastly, I just want to draw your attention to something which has been a little neglected in the story of COVID, and particularly with regard to variants, and also with regard to vaccines. We speak a lot about antibodies. And the reason for that is, in a viral infection, antibodies are the first line of defense. If you have good antibodies and they have a specific function called neutralization, they will assist to block the infection. There are some exceptions. HIV is the classic one. You can have massive amounts of HIV antibodies. They don't block infection coming in. You can easily be reinfected. And secondly, instead of neutralizing the virus, they actually are what we call enhancing antibodies. They make the situation worse. That's a talk for another day. But certainly in COVID, we believe that antibodies are important because typically they will help to block the onset of infection. But antibodies are not going to catch every single virus. So it's becoming clearer and clearer that the cells of the immune system are key to providing protection and perhaps also providing long-term protection once one's antibody levels start to decline. So which are the cells which we're interested in? They are particularly the so-called T cells. So T cells can actively go and seek out and kill the COVID virus. As you can see in this little cartoon, there's a big, very active, aggressive T cell, and you can see it engulfing and then destroying the SARS-CoV-2 virus. And it can also clear, or the cells can clear established infection, because what they can do is they can spot human cells, which are already infected, and they can destroy that infected cell. So they're extremely important. And these functions are done by different types of T cells. The CD8 cells or cytotoxic cells really are primed to clear established infection. The CD4 or helper cells are very important because they support antibody production against the virus. So they enhance the body's immune function, and that's a spelling mistake. They also stimulate natural killer or NK cells, which are able to directly attack this germ. What's very important about cells is that once they've done their job, these CD8 and CD4 cells, they settle down to a very quiet life and form what we call memory cells. So even though your antibody levels may decline, if you have good memory cells, we believe that it may be possible on re-exposure or revaccination for the body to much more quickly draw on that immune memory and rapidly produce high levels of antibodies. This has become so important that there are already new types of vaccines that are in trial that specifically activate cells as well as producing antibodies. And in fact, one of the first trials of this is currently being done in Cape Town at UCT, and it's going to be fascinating to see ultimately what this gives us. We think after a natural infection that we do have these memory cells as well. So that points again to us looking at only half of the picture when we do antibody tests in the laboratory. We're not looking at cells. People are investigating whether there's a clinical need to do so and how it'll help us. But we mustn't forget that this arm of the immune system is probably as important as antibodies. I want to finish off just by going right back to the beginning, because I've suddenly thought of something that may be of interest to you from the lab testing point of view. Sorry to rush through all of this. Let's go back to the genome, which I'm showing you here as the top little bar above the white series of blocks. So we've spoken a great deal tonight about the spike protein. That is the part of the virus which not only gives rise to the variants, but which is the basis of all our current vaccines. It just occurs to me now that the antibodies that we measure in the lab, and this is all laboratories, because it's the only test that's been approved for use by SAPRA, is a test which does not look for antibodies to the spike protein. It looks for antibodies to this red region here, what we call the nucleocapsid of the virus. So at the moment, please be aware that when you are doing or sending a test to the lab for COVID antibodies, you are looking at a result of antibodies to the nuclear capsid, which is very stable. And so irrespective of variants, if someone's ever had the virus and they've had it sufficiently severely to make antibodies, that test will always be positive. But if you or somebody right now is going for a vaccine and you do your antibody tests to see what's been the response to the vaccine, it's going to be negative. Not because the vaccine didn't work, but because SAPRA does not allow us yet to run a test for antibodies to the spike protein. So we're giving the spike, but the test we're doing has nothing to do with the spike. So don't rush to start looking for post-vaccination antibodies at this time. Let's wait till we have the right test available to show this. And when that test's available, we are expecting it to be quantitative. So we can say, yes, there is this much antibody or that little antibody, and hopefully that'll be of some clinical utility. So I think I've come to the end of the story. Yes, I have. It's been a bit of a long one. If anyone is still with me, I'm happy to take a couple of questions. Don't want to keep you all from your supper, but thanks for attending and listening to this, and hopefully you'll find some of it useful.
Thank you very much, Dr. Miller. I think it was quite a in-depth look at the virus, the variants, and the vaccine. Quite a detailed study that you've taken us through, and I'm quite happy about that. And we're still around with you, still got lots of questions, and many people who are logged in. I'll go straight to the questions, and I think for participants, if you still have a question for Dr. Miller, please do post it on the chat group, or once we've gone through the questions, just unmute yourself and we'll ask Dr. Miller to respond to the questions. I think the first question, I think, let me just go back to the beginning. So it says, what is the role or the place of rapid? I think you've just gone through that antigen tests. Perhaps if you...
Okay, sure. I think that's a really good question. Okay, so the advantage of the rapid test, as the name suggests, is to give you a quick answer. And the tests do give a quick answer, but the question about any test is to know whether you can trust the result. What we know about the rapid tests is they are pretty good in picking up infection in people who are symptomatic. So if someone has fever, respiratory symptoms, and you do a rapid test, you are very likely to get a positive result. And if you look at the actual figures, it's around about 95, 96% of symptomatic people will show positive. So very quickly, you can triage your patient. The difficulty comes in the asymptomatic patient. And in the asymptomatic patient, who we know is able to transmit the virus, who may get sicker over time because you don't know where in the course of the infection you're doing the test. In the asymptomatic patient, you're going to miss anywhere between 30 and 40% of infected patients. So I think the role of the rapid test is in the assessment of symptomatic individuals. There, you're very likely to get a reliable result. If someone just, or they have minimal symptoms, a negative test does not mean the test is negative. what it means is if you're suspicious, that's exactly the person who should have a PCR test. And that is the best data that we have on this kind of investigation. Doesn't matter what the brand is, how simple or complicated it is to do, these figures are consistent internationally. So it's very useful to screen and triage symptomatic people. It's not that useful at all for asymptomatic people. And for that reason, we say, think twice. If the patient's not very symptomatic, rather go for a PCR, because you're going to miss at least a third, if not more, of the people who actually have the virus.
In a hospital setting, if a patient comes in an emergency and the surgeon wants to go to theater, will that test be helpful for the surgeon to go and operate and treat that as if the test is positive or negative? Will that have any bearing on how to prepare for the surgeon use of PPE source?
This is the kind of critical question, and that's why a certain hospital group, which is not yours but well known to you, uses the antigen test as an admission triage intervention. So the answer to your story is, is just what I said. If someone comes in, let's say they've got air under the diaphragm and they need to go to surgery immediately. In that state, you're not going to be able to really assess them for COVID symptoms very accurately. An antigen test is, you've got a 50-50 chance of it being reliable. So that patient, we would still say, regard as a patient under investigation, and don't entirely drop your guard. And of course, the most important thing in that setting is the anesthetist and the post-op nurses, what's the word I'm thinking of? You know, once the patient wakes up, those are the important people who need to take special precautions.
I think we can ask...
recovery, that's the word I'm thinking of.
Yeah, Kamachal, I think just intervene. Somebody's sharing a screen. I don't know how they got into this. If you can just deal with that quickly, because they've not taken away my questions.
Yes, I see there's a question here which says, patient with symptoms, PCR negative, rapid antigen positive, negative. Can you confidently say there's no infection? The answer again, you know, is no. You can be, I would say, you can be at least 95% confident. And the reason I say this, and we've seen these patients, and they're well reported internationally, is as people become sicker with COVID, the virus is not present in large amounts in the upper respiratory tract, but migrates down into the lungs. And so we've had a number of situations in which the attending doctor will say, this patient's got COVID. I've done 2 PCRs, they're negative. The D-dimer is up, the IL-6 is up, the patient is hypoxic. This is COVID until proved otherwise. There's something wrong with your test. And you then say, well, you know, if you're going to be doing anything invasive, which we don't advise you to do, but if there is a clinical need to do something that involves sampling the lower respiratory tract, please give us a lower respiratory tract sample at the same time. And we found those to be strongly positive. So I think your confidence level, if the patient is negative, rapid PCR, and they've got symptoms, you can say with around 95, 96% certainty, this isn't COVID. But there's going to be those few people who actually have the illness. I think here it's worthwhile to look back at the original reports from China, December 2019, January 2020. What they did in China was they had a case definition as well as a laboratory confirmation. So they weren't able to test by PCR every single patient that came through their doors. But if the patient had a clinical illness and other supportive lab tests and a radiological evaluation that was consistent, whether CT or good X-ray, that patient was regarded as COVID. So I think there's always going to be that very small number of patients who will have COVID despite having negative tests from the upper respiratory tract. It's going to be few. I mention it, I suppose, it's like an exam. If you see all or nothing, it's a wrong option. And I think that's true when it comes to this kind of testing as well.
I think that it answered the questions about specificity and sensitivity. Okay, then there's a question, are there tests that can ascertain whether the administration of vaccine has induced protective antibodies in the vaccine recipient?
Yes, in a clinical trial setting, those tests are being done. As I said, we don't have permission to offer those tests yet. And this is, I don't know, what does one call it? Administrative red tape, because the tests are available. We've all evaluated them, but we're not allowed to run them diagnostically until they're approved by SAPRA. So once those tests are approved, which are going to be tests for antibodies to the spike protein and quantitation of those antibodies, we can answer that question. Until then, where we can only offer tests against the N protein, the nucleocapsid, we really can say nothing about vaccine-induced antibodies.
So there's not much that you can say what's going to happen after immunization with?
No. So what we're suggesting to people is, if you're interested we know that the antibodies peak somewhere around between 40 and 60 days. So if you're interested in knowing what the result was, by all means, speak to your lab, to one of the people in the virology or immunology section, ask if they will store the blood and test it when the test becomes available. And I know certainly we'll do that. We're already archiving specimens for that day. So I think everyone will be happy to offer that service now, but the answer is going to be delayed. There we are hamstrung by the regulatory authorities.
Okay. Yeah, there's a question as to, now that we're still giving the vaccines to the healthcare workers, just early stages of phase 1 and phase 2 and 3 not yet there, will there be any benefit in giving polio vaccination to the older people while we wait for the COVID vaccine to be rolled out later on?
Sorry, I didn't catch that. Did you say polio vaccination?
Yeah, polio, yes. Yeah, I think that's a question from Veronique.
Okay, I'm not sure why you would want to do that in an adult, because it's a childhood vaccine and the immunity it induces is really complete and very, very long lasting. So the only time we recommend polio vaccine as a routine is in those few of us who work in viral culture laboratories and where we might isolate a polio virus. So we want to be sure that we are protected. And what we do is as a routine, check polio antibodies, and then if necessary, give a booster. But there should be no other indication that I'm aware of to give polio. No, to stimulate the immune system, no. I don't think that's of any benefit to anyone. Because don't forget, the one downside of the polio vaccine, if you're using the oral vaccine, it's a live vaccine. And the only polio that we see today is vaccine-related polio, where the virus mutates to become a little bit more virulent, and then is spread from the infected person, from the vaccinated person, to a susceptible person nearby. It's usually not a very severe disease, but that's the only polio that we're seeing, certainly in Africa, and it's very, very rare. But any vaccine will boost your immunity, but only to the vaccine. It's not designed to make your entire immune system overactive. That's actually damaging. And just to bring it back to COVID, that's what we think under that mechanism of overactivation is what leads to many of the critical problems in COVID. So no, don't give vaccines to so-called stimulate the immune system.
Yeah.
Vaccines will only give you a specific response to what's in the vaccine. And if you don't need it, don't do it.
Yeah. Now, this one is a futuristic or optimistic view of COVID. Whether will we one day live in a COVID-free world?
Well, as you say, it's an optimistic view. I think we might live in a SARS-CoV-2 free world, but I wouldn't go so far as to say there won't be a SARS-CoV-3 or 4. And the reason for that is we don't yet know what the source of the virus is, which animal. And as long as we have viruses that have their primary reservoir in animals, there will always be episodes of introduction into human communities because of the close association of people with animals in many situations. I mean, we see that situation now in West Africa with Ebola. There is an Ebola vaccine. It has been given to a lot of people, but epidemics periodically arise. And that's because we can't clear the reservoir. So there's always a risk of that virus coming back. And since we know that coronaviruses are widespread in animals, particularly in bats, and that's again a very fascinating story. You know, why don't bats get sick from coronavirus? But that aside, the reservoir will always be there. And so I think in time it will come back, maybe in a different form, even though we are likely to control the variant or the version, I should say, the SARS-CoV-2 that's around now. It's certainly not behaving like the SARS virus in 2009, which killed a lot of people and on its own and for no obvious reason disappeared. Clearly, this SARS-CoV-2 is an evolution of that, which is much more adapted to humans. And it's quite likely that that will continue over the next few decades. But we'll call the virus something else.
Okay, this next question, I think we've got only 5 minutes left. I don't know how much time you have, but I think, what is the purpose of the pan or universal vaccine if as vaccine will work on? You seem to be familiar with that question.
Yeah, so this is the holy grail of coronavirus infections. So if you go back to the structure of the virus, there are some elements which you will find in every single coronavirus type, whether it's a cough and cold one, whether it's SARS, whether it's the MERS virus that is still ongoing in the Middle East, whether it's COVID. And the wish that scientists have is to develop a vaccine that will protect you against every kind of coronavirus. And that's what's called a pan-coronavirus vaccine. The chances are good they will succeed. When we look at how much success has happened for the current coronavirus, there's a high likelihood of success. If that's achieved, then we are looking at no further human transmission, provided everyone who needs the vaccine can have access to it. And that, of course, is more of a political, economic, social issue. But yes, that would be an incredible thing. And it's certainly what people are planning to do. So it's not beyond the realms of possibility.
Okay. Yeah, I think one of the last questions, should a person with long COVID symptoms take the vaccine?
Okay, so long COVID, again, is a fascinating condition that's only now becoming understood. One of the underlying factors in long COVID, or to give it its new name, it's called persistent immune activation post-COVID. It's got some new acronym, is that the immune system has not settled down to its normal level of peace and quiet. There are still elements of the immune system that are active, producing levels of cytokines that are not healthy. And it's probably that which is responsible for these ongoing symptoms and multi-organ symptoms. So in that situation, you do not want to immunize somebody too soon, because by flaring up the immune activation, you might make them sick, feel sick again. Okay. So the recommendation is that if someone has had COVID and their symptoms have completely resolved, you must wait a month before you vaccinate them. In someone with long COVID, you should probably wait 3 months as a minimum after the main illness has resolved, and then consider vaccinating them. And the reason why we vaccinate everyone is because of what I said earlier. The antibodies you produce from natural infection decline, and they will only protect you for between 6 and 9 months. So by giving the vaccine, you're giving a booster to the immune system to make more antibodies for longer, and you're getting a much better level of protection. But just be a bit cautious in the long haul COVID people and wait at least that 3 months after the worst is over.
Okay. Yeah, there are many questions, but I think I'll just take this last one because it's quite topic. I think it might give us some indication where we should be going. Shouldn't we be giving the AstraZeneca vaccine to the elderly so long? I mean, because
Yes, absolutely. Absolutely. So we know the vaccine works, okay? If we look at the South African study from which this poor data was assembled, it was a group of 2,000 people, which is very small for a clinical trial. Normally in a clinical trial, you're looking at 70, 80, 90,000 people. And they were all young, and they all had issues of compliance and a couple of other things. So they do not represent the general population of people who are going to get sick with COVID. We know that AstraZeneca works. It's working everywhere else in the world. And if we've got it, I think it's wrong not to use it. And certainly, as I said earlier, you can always boost at a later stage with something else, but at least get the protection there. And I think if you ask anyone in the immunology, virology field, they'll say, take the vaccine, get the protection that it gives you. We will soon be able to measure that protection in a reasonable way. and we can then decide who needs the boost. But at least you will stop people from going to hospital and dying. And I think that is a major advantage. Just as a last word, I'm just thinking, there are other vaccines we use on a daily basis. Think of rotavirus is the common one that comes to mind. All kids get rotavirus. It doesn't give you the protection that AstraZeneca does against COVID. It doesn't completely stop children from getting infection or ill. But we say this is good enough because we're not going to get fatal diarrhea. We're not going to end up with children who die of a preventable condition. The AstraZeneca vaccine is kind of in, even with the current data, is kind of in that same category. It's useful. We've got it, or we had it. I don't know what its status is now. And I think it's a pity. I would say, and it's a personal opinion, not being critical of anybody, I would say it was a wasted opportunity. So whoever suggested using it, that's my long-winded way of saying yes, absolutely.
Yeah, I'm sure you've got a lot of support on that. Okay, thank you very much, Dr. Miller. It's been quite an interesting evening, and we hope to see you. I don't know, should I say that after the third wave?
Hopefully I'll be walking with a stick by then.
Yeah,
so.
Yeah. I'm not sure if Dr. Brenda is here with us, Dr. Brenda. Oh, she was going to join another day. Yeah, she gave an excuse, but she was going to join us if she was able to step out of the other webinar that she was invited in.
Okay.
But I just want to take this opportunity to thank you on behalf of Health IQ Consulting and Clinix Health Group. I see Dr. Kenosh is here also from Clinix Health Group, our Chief of Operations. And to say thank you for being with us. And I think this information is quite valuable. I think the number of questions that we have are still about, what does Dr. Brenda has joined us, 23 more questions. So I'll just hand over to her to just do the closing remarks.
Thank you very much.
Dr. Brenda, you can unmute yourself. Kamukhal, if you can help Dr. K to unmute yourself.
Hi, Doctor. We seem to have lost Dr.
We've lost Dr. Brenda. Okay, no, that's fine. Yeah, but I think just thank you. Yeah, I think thank you. And also to all the participants who joined us this evening. And we know that you're quite keen on joining us. Please know that this presentation, I think, will you be able to share it with us, Dr. Miller?
Yes, of course.
Yeah, okay. Yes, I think it will come from our marketing department, and we also
correct.
We're recording this, and I think with the permission, if it's okay, we can share this recording. Sure. Okay, and thanks everyone, and we hope that we had a good discussion this evening, and we do not want to hold you any longer. But please stay safe, keep healthy. We shall see you again next week, 18 hours. Bye bye.
Thank you. Bye bye, everyone.
Sure.